Hey everyone, it's Elizabeth Walters with HIVE Nurse here at Live with the Hive. We're recording a podcast today on building really good practice-ready nurses.
Hey everyone, Ashley Kellish here, the co-founder and supporter of Elizabeth here at HIVE Nurse, and we're really excited to talk about this topic today, mainly because we have really seen a gap in what our academic partners are trying to produce and their sort of goal at the end of their journey with our newest nurses today, and then the clinical setting and what our nurses are being prepared for and how they're prepared to enter into what is a pretty complex work environment today.
Really complex. So let's just sort of start out and talk about what nurses do for those of us who are not nurses, right?
Yes.
So nurses, essentially, in order to become a nurse, you have to go to nursing school. That can be an entry in an associate's degree, a diploma program, a bachelor's degree. There are some MSN entry to practice degrees, etc. And so, but essentially it all boils down to you take some general education credits and then you take some nursing classes. Those nursing classes incorporate clinical time where you're spending time on the shift in a hospital, working one-on-one with a nurse and and a clinical instructor, in addition to didactic courses. At the end of that, we're really preparing for one really, really important thing. What's that important thing, Ashley?
To take a giant test called the NCLEX, which I don't know what it stands for. There's something about national and certification in there, but it's basically a test that you have to take after you complete all of this coursework that Elizabeth just described that says now you can get your license to practice formally as a registered nurse. So, and I think it's actually what you said is really important because there's multiple avenues to become a registered nurse. So you can have multiple different degrees.
Right.
And in fact, if you look at some of the literature out there today, we have really pushed in our practice environment the need to have a bachelor's degree.
Correct.
So that's a 4-year college, which I did that.
I did that too. Yeah.
It's
I went straight.
Routine.
Yeah. I went straight to college out of high school, but it's not a typical path for nursing. In fact,
it's
in
not.
the institution I'm teaching at now. Often, most of the nurses that I'm teaching in their leadership courses are nurses who got an associate's degree and are now and they are practicing as nurses. They are registered nurses. They have jobs. They work on the floor. They work in clinics. They work all over. And now they're coming back to get their bachelor's degree. And so they're getting that sort of like extra content that people get during the bachelor's program. And so there's so many entries into nursing. And there is a big push in nursing to have bachelor's as entry to practice. And there's even some talk in academia about a master's entry to practice.
Yes.
But there is multiple roads to enter into nursing.
And the idea that you need one degree over another, I think, is what bogs the system down in a lot of ways.
It totally does.
It also changes the hiring opportunities for a lot of people in different healthcare systems today, especially our magnet healthcare system. So Magnet is that big accreditation that the American Nurses Credentialing Center offers hospitals that show excellence in nursing care. And one of their key goals is that you have the highest amount of bachelor's prepared nurses that you can have. Now, I don't disagree with any of this. I think it's important to have the highest level of education that you can and the highest level of ability to practice in the clinical environment. Where I see the gaps on the clinical side is that no matter which school or program you have graduated from to take that test, I'm not necessarily seeing you ready to practice when you come out of nursing school.
Correct. And that's why we've developed, not we, Ashley and I, Ashley has done this, but they've developed practice transition programs.
Yes.
And so in addition to your schooling, as soon as you get out, you're not ready to just jump on the floor and take a patient.
No.
You need to learn all about the hospital system that you're working in. You need to learn about the policies and procedures there, your own state's Practice Act, etc.
Yes. And there are amazing programs out there, new graduate residency programs they're called, where you can spend a lot of time not only in with what's called a preceptor, so someone who's going to train you side by side, and you might have multiple preceptors actually throughout your orientation stage, which is typically 6 to 8 to 12 weeks, depending on the budget capacity of the
Yes.
hospital to
Yeah.
train you is what it comes
Yeah.
down to.
It really does come down to it.
And the level of patients that you're going to care for. But how do we really transition nurses prior to that entry into practice? I think is the question that I'm always asking myself. What could we do better as academic and clinical partners to say, you know what, Elizabeth, we have graduated you from X school. You have X degree. I don't even care which degree, honestly, that you have, but you've taken your NCLEX. And I am confident that it's not going to take us very long in the practice environment for you to be successful. Because guess what we're seeing? We are seeing routinely at the 6-month mark that nurses have spent in their first job, that the burnout goes through the roof, that their eyes are wide open to the environment that they have chosen to work in, and they don't want to do it anymore. And we're seeing them crash down. We're seeing them change jobs. We're seeing them leave nursing altogether.
Yeah.
And when you ask them, they say, I didn't know this is what I was signed up for. So
because they spent the whole time they were in nursing school getting ready to take a test. Right? They weren't getting ready to go into the practice environment. I mean, there were experiences which were not realistic, right? Like when I was in nursing school and I teach in nursing school now, the nursing students pair 1-to-1 with a patient.
You don't ever
do that again for the rest of your nursing career. You never pair 1-to-1 unless you have the sickest patient in the hospital on 14 different machines. And so it's really like one nurse taking care of 14 patients because they have 14 different machines.
Yes.
So it's sort of unrealistic what happens in nursing school. And we spend a lot of time learning how to take this NCLEX exam, and we spend a lot of time preparing for it. But we don't spend a lot of time really just getting ready for what it's going to be like. I think that the best new graduate nurses that I've ever worked with as a preceptor have been those that practice as nursing assistants first.
Yes.
The ones that actually spent time, energy, and effort in patients, taking care of patients, learning how to talk to patients, learning how to assess them, learning how to notify, learning how to delegate, etc. When they have done that first, they do so much better in the practice environment. They understand what the real practice environment is like.
I was a nursing assistant.
I was a nursing assistant
now
too.
Now that you say that, I was. And it was actually one of my favorite jobs, to be honest, at that time in my life. And I was, of course, working like 6 jobs, but nursing assistant was one of them. And I would work night shift. And my sister-in-law at the time was a nurse on the floor. She was the one who helped me get the job. And so they would pull me into stuff all the time and show me ahead of time. And it was just that showing, that seeing, that context that you gained that made that experience for me a little bit less shocking, I think.
Yeah. So why doesn't nursing school prepare us for that clinical environment?
Well, I think we could.
Or what can we do to help prepare nurses for that clinical environment?
I think a couple of things. And I have had the benefit of actually building some pretty amazing academic practice partnerships along the way. And I think some of the strategies that we have done are really trying to engage the faculty at the teaching level to re-engage back in the clinical environment and actually worked on building faculty in the clinical environment. So we did this amazing program at one of the organizations I was with, and we're actually repeating it at another one now, where the nurses who are working at the bedside work 2 shifts. And then their 3rd shift is as a clinical instructor for those nursing students in their last semester.
That's pretty
on their unit. So because they have all the knowledge of the hospital, all those things you said, policies, procedures, access to who's who and what's what, they actually give students a better experience. So I think that's one pretty simple strategy.
It's a totally simple strategy. And it also helps elevate the bedside nurse to that teacher in that leadership professionalism role that we're always trying to strive for as nurses, is to advance in our clinical ladders, or however we want to call that, hierarchy, essentially. I can tell you, as a person, I was a clinical instructor. I had been away from the bedside for many years. I had been away from the bedside for about 5 years and came back into clinical instructing. And on a unit that I had never practiced on, in a patient population I had never practiced in. And I feel like I wasn't prepared as a faculty member
Right.
to take students on this floor. And I had to lean so heavily on the bedside nurses to teach me things. And so I actually precepted with one of the bedside nurses for about 2 weeks before I came
wow,
on.
that was commitment.
Yeah. And it was unpaid because I knew I wasn't ready to come
Yes.
onto the oncology floor.
Yes.
And so, I was able to sort of immerse myself in the unit culture and spend some time being precepted by a nurse so that I could be a better clinical instructor, so that I could say, this is where these supplies are. This is where the med room is. This is how this unit does this medication timing and dosing and all these things, right? So it was really, really helpful. But I definitely think that that's not something that is a commitment of
that's
many
not the
faculty
norm.
members.
No, it's not. And if you think about it, it's even hard for an academic place, a school, to even think that narrow because they're trying to prepare nurses for anywhere. And maybe that's part of the problem. Maybe you come to this nursing school and we're trying to prepare you for any hospital in the world is actually hurting us in the long run.
Right.
When maybe we would do a better job if we were very honed in on this specific area you were.
If we went back to the diploma nursing.
Oh, don't even bring it up because I already got in big trouble with a dean that I was working with. This was one of the first conversations that I had with this person. And I said, I don't see anything wrong with when we were in nursing school in the hospital setting. And it did not go well for the rest of the conversation. I was told that we are never going back there, that erodes the profession. I don't think it does.
I don't think it does
actually
either.
would bring us back to what our profession needs, which is how to care for patients.
Right. And also how to care for your community. Right.
Yes.
I mean, this sense of, one of the reasons my son wants to be a nurse is because he can live in a van and travel all over the country and hike on the weekend or hike on the days off and then practice during the 3 days, and have health insurance and a 401k and all those things. But, gone are the days of that sort of loyalty to an institution.
Right.
But when you do talk to nurses that earned a diploma from a particular healthcare system, man, they are in it. They stayed in it. Like there's still a diploma program in Delaware, and I went to school in Maryland, and those nurses that went through that diploma program worked at that same hospital the entire time, and they did the same thing. They clinically precepted people.
Yep.
They were instructors within the diploma program. It was all sort of like a one-stop shop for those nurses.
Well, and what's wrong with keeping your learning closest to what you're trying to become? I think over the years, we've gotten very far away from this is what it is to be a nurse, and we need you to learn this. When they graduate and they're in your environment, then you can teach them a lot of the stuff that these nursing schools are actually honed in on. But then you can teach them professionalism, how to go back and get their certification, all of that extra stuff. But in the moment, we actually just need them to be competent in the skills that allow them, A, to be able to practice safely.
Right.
But B, to know how to ask questions, to know the environment that they're stepping into, to not be concerned that they have 4 to 5 patients when they graduate. That's realistic. That's
and
what
to be confident that they can say they don't know the answer.
Yes.
Right?
Yes.
This is actually I have a great story about this. So when I was an APRN student, when I was a nurse practitioner student, I was precepted by a physician that in an academic hospital. And so I would come, and it was an inpatient consult service, and I would be on consults and I would be on rounds, and I would have the med students and the residents and the fellow with me, and we would present our patients, and the attending would say, Elizabeth, blah, 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 why, what's going on with this patient? I'd be like, you know what? I don't know. I have to go back and figure it out. Like, I have to go back and look at those other labs you said that we should look back at.
Right.
I need to do those things, and I need to look into the literature. The senior resident looked at me like I had 14 heads at the same time because I was like, I have no idea.
Right.
But
That's why I'm here learning.
that's why I'm here learning, right? And so
Yes.
that's not necessarily the medical model.
Right.
And that is one thing that I feel like nurses are really good at. Like we teach nurses from the day one in the hospital, like it's okay to say you don't know the answer, but you know where to get it.
And no question is a
Right?
dumb question.
And-
And
Right.
those are some of our best nurses are the ones that come out and they're not afraid to say, hey, something feels off here. But how can they ever know that if they don't have enough context?
Right. And how can they know that if they only have one patient?
And if you actually look at our environment today, since COVID, the amount of clinical experiences not has decreased because during that time for at least 2 years very little were in the clinical environments
Right.
because hospitals would not have any extra people there, right, wrong, or indifferent. It's how it was. So we're still recovering from that. And then when you look at clinical experiences today, they're so short because now we're pushing nurses through these programs so quickly. And because we've set all these rules and regulations, you have to have this much time in the classroom, this much clinical,
this much time in the simulation lab, which we both love simulation.
Yes,
we think it's a great tool, but it shouldn't be replacing those patient experiences.
Or why can't we put our nurses in the sim lab with
the students?
So that you're getting real context at the same time as that practice environment. So instead of I think that's where our biggest gap is. So, okay, let's get back to a couple strategies because we're going all over the place. We're buzzing around here at the Hive, which is what we do. But number one, I think inviting faculty that are clinical staff. Huge.
Yeah. So in order to take a clinical group on a unit, you should be a nurse on that unit.
Yes. You should. Yeah.
Like we should eliminate the people like me coming in that have never even seen that patient population because I don't have the context.
No, I think we focus. And then also that can help with burnout on your unit because it gives your staff a break for a day, for a shift. They get to have 8 students that they get to support. It might remind them of the joy of nursing and bring them back to what it was like for them as a new nurse.
There is nothing better than teaching in the undergraduate program, in the clinical environment. You tell those war stories to those brand new nurses and they look at you with these like doe eyes and like you're some sort of hero. I love teaching in the undergraduate environment, especially in the clinical environment, because it does make you feel amazing about the work that you've done over the last 20 years.
Yes, absolutely.
Yeah.
Okay. And then I think second strategy that we've called attention here to is looking at the curriculum in nursing schools.
Right.
And really trying to beef up if we can't go back to diploma or, hospital-based.
We're not going to be doing that.
And we're certainly not going to be doing that.
No.
Then what can we do to beef up the experiences? And how can hospitals really focus and partner with schools? I will say I have had some beautiful relationships with academia and even looking at the new competencies, the new essentials that are out. We have actually asked our practice managers in one group that I'm working with to review those and align them with their units so that then the faculty can say, oh, we're going to send you here, here, and here because you're going to learn all of these competencies.
Right. Yeah.
So really trying to teach the clinical side, hey, this is what we're trying to get to. How can you help us get there? And being very intentional about that.
Yeah.
Not just assuming.
And making school be more aligned with the practice environment.
Yes.
Right? Like
more realistic.
It needs to feel more realistic.
Yes.
Like the whole thing about when I taught in the clinical environment, we had post-clinical.
Oh, yes.
What is it called?
The debrief.
The post-clinical debrief, where we came in the morning and the nurse students were able to get report from the nurses, but we left because they were only there for 12 hours. And so we would leave at 6:00 and they wouldn't get to see the handoff part and they wouldn't get to see how to give report. And I was like, gosh, this is like such a
miss.
We're missing out on things here. And so, like how do we reconfigure those experiences? Yes. And I think that, I love the debrief. I love being able to get together with the students at the end of the day and talk about what went well and provide feedback and things like that. But maybe that can be done in a different way so that the nurses can actually do and give report, the nursing students.
And then I would say the last strategy is on the clinical side in ensuring that you have a really well-defined transition to practice program, but that you've met with your area schools that you're taking new nurses from. And even obviously if you're hiring people from out of state, but that you look at their curriculum and then you look at what you have and you try and align it so that it doesn't feel like such a shock. Because I think even in those initial weeks when you have preceptors and you're orienting these people, you actually have a real opportunity to even, let's look at it differently. Why do we have to precept 3 12-hour shifts? Why can't they be 5 8-hour days, and really get in there with them and make sure, as your educators are working with them and your preceptors are working with them, that you're hitting the mark with what they need to see before you let them loose.
And something else that you mentioned was the importance of continuing on those AACN essential competencies, right?
The practice
They do not end.
No.
They are not meant to end at the end of the bachelor's or associate's degree or diploma nursing, right? At the point of RN. They're supposed to continue through your entire career. You're supposed to use those AACN essentials as a roadmap to competency for your entire career. We look at those essentials all the time and the competencies. And there are multiple competencies that I wouldn't even say that I'm totally competent at.
Well, there's over 400 of them.
Right.
But this is actually the whole point of what we're trying to do, which is make this stuff accessible. Because think about your clinical partners. Think about people at the bedside. They don't know anything about this.
I mean,
they don't have time to know anything.
A lot of people
this.
don't even know about the new competencies.
No, absolutely not. And so we are trying to make it accessible. And I think that's the last thing that I think, as we wrap this up, that I want to highlight is that we have created a wall between academia and practice.
Yes.
And there is a sense of duty to both sides that is very hard to pull together.
Yeah.
Even when you're trying to all focus on the same goal, which should be about graduating these students. But I do think it's time that those groups that are doing this well, that are building true partnerships where egos have been left at the door, and both sides are coming together to say, what can we do differently so that these nurses are practice ready, are not shell-shocked when they get on orientation, our preceptors are trained and ready, our faculty are relevant and clinically able to do this
and
at the bedside.
Clinically competent.
Yes. Yes.
Like, not someone like me who came in and was like, I wouldn't have felt comfortable taking patients on that unit.
Well, and you are a good person that you thought about that, because I do think being a clinical instructor is a super huge responsibility. And I also think that nursing schools are short of faculty. And I'm sure if they were listening to us, you're like, oh, who are you two in your glass houses? But the point is, we need to think about it differently. We can't keep using the traditional paths to get a different result.
Right.
Definition of insanity, doing the same thing over and over, expecting something different.
Right.
If we want different nurses, we have to train them differently to graduate.
Right. Awesome. Well, thank you guys so much for joining Hive Nurse today. Don't forget that you can listen to this podcast on hivenurse.com. Join the Hive, and you can get CE credit for listening to the podcast and doing a short reflection activity. We can't wait to see you in our online space. And also, please follow us on YouTube, Instagram, TikTok, Facebook, all the things at Hive Nurse.
Thanks so much for listening. And I think this is a conversation that we will probably be having in a different way again and again. So
yes,
thanks.
Yeah.